Great. So today's webinar, titled Actionable Steps for Managing Maternal and Infant Health to Improve Outcomes While Reducing Costs, is brought to you by ProgenyHealth. ProgenyHealth is a longtime MHPA Silver partner and a great supporter of both the association and our health plan members. I'd like to thank them for pulling together today's session, and we appreciate them coming with all this great information. With that, I'll go ahead and turn things over to Wendy Milligan for introductions and today's content.
Great. Thanks so much, Eric. Appreciate the opportunity. As Eric mentioned, we're very excited to share some insights with you all today. And also just looking at the clock here, we're just under a month out from the conference, which we're also excited that we're going to have a panel and have a couple of our current clients talking about some of the outcomes. So excited to share some tips today, and then hopefully you'll be able to join us on our panel and learn right from our clients some of the outcomes that they've seen. Before we get started, just to kind of give some context to what we're sharing here today, we are well aware that just about every single health plan in the United States, especially Medicaid plans, has as some of their corporate strategies and initiatives around maternal and infant health. And we know that there's varying initiatives going on, and it's not an easy battle, and it takes all of us together, working together to do that. So the goal of today is to really help you all gain some immediate action steps that you can consider and understand more about your population health needs and have a direct impact. So we're hoping to have this be a very informative webinar, give you some very practical tips and action steps. We all know that the actions you take today will have an impact on tomorrow's spend. So hopefully you'll walk away with a long list of actions that you can go ahead and immediately execute. For those of you who aren't aware who ProgenyHealth is, we have been in the maternal and infant health space for over 22 years. We were founded by Dr. Ellie Stang, who saw all of the opportunities for better collaboration, proactive identification, integration, all working together around maternal and infant health. And advance that forward now today, we are delivering solutions that not only are multimodal, but are high touch and high tech. And we'll talk a little bit more about that. We use the insights from millions of data points to really drive evidence-based decisions and help our clients and our members guide them as to where to focus and how to bring the most impactful outcomes. So very excited to lead this discussion today. And I'm going to go ahead and advance this over and turn this over to my colleague, Brian Shibler. Brian is going to share a little bit about his background, as well as bring some insights. Brian is right on the front lines, talking with many of the folks probably on this call or other health plans like yourself, and has some wonderful context that he's going to share about what are the most common challenges, successes, different ways that he's been able to help health plans and also help them identify opportunities. So with that, Brian, I'll go ahead and turn it over to you.
Thanks, Wendy, and welcome everyone today. Our hope is to simply share with you what we're learning nationally across the country with regard to maternal infant health. And so, as Wendy mentioned, aside from the thousands of moms and families with regard to maternity and NICU care that we help every year, there are multiple health plans that we work with to evaluate and help them look at optimization of their maternity and NICU programs. And we thought today those who were in attendance would get some value out of just sharing what we end up finding on behalf of the health plans and some of the things that they find to be most compelling. So that's today's agenda. Just by way of the premise of our time together, we know that health plans nationally are struggling to find resources to manage the nation's escalating maternal and infant health crisis. We know that's true. They share with us that it's difficult for them to get the data needed to understand what exactly is driving the crisis and the outcomes and the cost. There's a challenge identifying the levers of rising cost, and we know that medical costs for newborns are some of the fastest growing in healthcare and driven mainly by infants requiring NICU services. And finally, they are looking desperately to find a way to arrest the declining outcomes. And so just simple premise for today's call. If you're not finding any of those challenges, any of your topics, I just got a note on my computer that there's an ad for a webinar with the explanation for understanding the closing ceremonies of the Olympics, which if you happen to see that, that could be a webinar that could be very interesting also. So let's jump into the agenda. So as we're working with health plans nationally to help them evaluate the health and functionality of their maternal infant health programs, you're right, Wendy, it is considered to be a national crisis. And naturally, health plan leaders are feeling the responsibility to help their members better navigate the sometimes rough water challenges of pregnancy, pre and postpartum. And I love the idea of doing this webinar to share some of these insights. Because we know that when we work together, we can make a measurable impact on key indicators like, maternal morbidities and mortality, infant mortality, preterm births, opioid and substance use disorders, costs of NICU care, unwarranted variation in care and costs across the network, racial disparities caused by limited resources, and we can control the impact of social drivers of health. So excited to talk about some of those things today. Important to note that we'll have some time at the end, as Eric and Wendy both mentioned, for some questions. If you all have questions that you didn't get the chance to ask today, or you feel like it needs a more in-depth answer, we'll have our information, our contact information available to you. Just don't hesitate to call us and ask us those questions. We are here today to help you, period. Could we jump to the next slide, Wendy? So let's dig in with helping you all to make the case for investing in the management of the full maternal and infant health continuum of care. So the visualization of these dials is often a bit of an epiphany to health plan leadership when we dig deep into their NICUs. And the slide depicts what we're seeing nationally. So the left dial represents volume of newborns comparing NICU admissions to well baby births. And you can see in that circle that 87% attributed to well baby and 13% attributed to NICU admissions. If you cast your eyes to the right dial, it expresses the total newborn population related to cost. And you can see that the graph nearly flips to the total cost being generated from NICU admissions being 85% of the total national total cost of newborns. So that flip is important to understand because, so for example, let's say you make a significant investment in your maternity program and in anticipation of reducing the cost of your total wellborns. And let's say you were able to do a fantastic job and you achieved a 25% reduction in your maternity program costs. It's important to understand that when you look at all newborn costs, you're only impacting 15% of the total newborn cost. So in essence, a 25% reduction on the maternity side of the house, that 15% is only 3.7%, 3.75% of the total cost. That same reduction of 25% in your NICU, 85% of the total cost would be 21.25%. So it's not crazy math. It's just important to understand that the key takeaway here is if you are intending to reduce your cost for your total newborn population, you must look at maternity and you must look at NICU and you must look at everything that happens pre and postpartum if you intend to take a real bite out of your cost structure. Important to understand. Let's jump to the next slide, Wendy. Simple slide. To me, based on everything I see, there are a couple keys. A comprehensive maternity NICU management solution has to be built intentionally to do a couple of key things. One, manage the full spectrum of risk from normal pregnancies to high pregnancies. I know a lot of health plans express to us that they feel like they're in a boxing ring with one, hand tied behind their backs because they can't get the resources to care for the full maternity spectrum, and so they're in default mode to only taking care of those moms that are high risk in those complex pregnancies. Got to expand that thought process. Number two is solving for social drivers and determinants of health. Those challenges are very real. If your team has in the past had a myopic view on the clinical side of handling maternity and NICU, you've got to expand that view to handle those social drivers because they are having a very real impact on outcomes and cost. And the third thing is, as you look across your provider network, reducing the variations in the philosophies of care across that provider network by bringing them additional value is really important in the work that we're seeing to control your cost while you're improving your outcomes. Number four would be to empower families through engagement, education, access, all of those things. In most cases, what we find is in the void of information, families default to things like the EDs and reaching out to sometimes the most expensive opportunities for care, or they default on the other side to not doing anything until it's too late, and then they end up in a situation that none of us wants them in. And then finally, you've got to keep in mind that, and we all know this intuitively, the member experience comes first. So as you're going to reduce those costs, you have to have a way to objectively be tracking the member experience as you're making those changes moving forward with reducing the cost. And by the way, just as a side note, managing that entire integrated continuum of care is the only way that we know, that we have found, to can truly deliver predictable and objective ROIs when you're looking at the return on investment in both dollars and outcomes related to health and quality. I think it's important too to note that I mentioned earlier some of the blind spots that we often find that health plans are experiencing. I just noted three of them today for our time together that I think are most important and compelling. Number one is controlling risk. And as that risk rises through pregnancy or even in the NICU. So one thing that we know when it comes to controlling risk is really important is having a way, a firm process to identify, triage, and facilitate timely intervention for rising risk through the entire continuum. And one of the best tools that I know we have for doing that, and it happens to provide high value to the members, is to use digital experience combined with risk stratified care plans for all pregnancies, not just high risk complex pregnancies. Having a way to monitor and respond to member engagement is a key to making sure you have your hands around rising risk. Like someone asking simple questions about things, could be swollen ankles, headaches, vision changes, you name it. But as a mom is engaged and she is using some of the tools you can provide for her to make sure she's educated and you're monitoring those tools, those kinds of questions often point toward potential risk like, hypertension, other things, preeclampsia, those kinds of things. You need to know they're happening as you are working with those moms through their pregnancies. And it's also important, I should mention, postpartum. And once you've created a trustworthy communication platform for them to use, our experiences, they lean into using that. And it gives us the opportunity for our case and care managers to intervene appropriately as needed. Because, the truth of it is, we can often intervene with those women who deserve the intervention that they need. So, second thing, very quickly, is team approach, and then we'll get to what we want to ask in the polling question. One of the things that I think do really, really well is we assign a full team to pregnant moms as well as NICU families as soon as we get the opportunity to engage with them. So that means with the NICU, for example, neonatologist, and CM enters the picture immediately, and we do everything we possibly can to make sure that we are keeping that team in place throughout the inpatient stay and then postpartum, and we keep that team in place through that baby's first birthday. It's important because the foundation of those relationships builds trust, and when that trust bond is built, that caregiver support family will share with our team the things they need to share that we need to know to be able to control risk. So I know we have a polling question coming up. We'll ask you all to go ahead and respond to this poll and what your thoughts are. Go ahead, Wendy. Sorry.
Thanks, Brian. Appreciate those insights there. And also just want to share, as Brian is sharing some of the ways that we're doing that, we'll also share in a moment some of the key levers that you can do and show some data points around how that can have an impact. So as you can see, the poll question here is, what are your top challenges related to maternal and infant health? And you can see some of those choices there. Go ahead and if you can select your answer there. I know Eric opened up the poll. While we're waiting to gather some of that, curious, Shiv, from a standpoint of what are you hearing from health plans? What are some of the, how are they showing up? Are they motivated? Are they feeling like there's challenges? Tell us just a little bit about what are you seeing when you're speaking with different plans about their ability to have an impact on their own maternal and infant health population?
Well, I appreciate the question. In general, teams are highly motivated to show progress with this population. Pregnant women and babies are truly at risk, and the resources are just crazy tight. It's a frustrating challenge for people. They know that a general strategy for NICU management is not going to make the same impact as a specialized support mechanism would, and they need results to help show the value to their respective states and things like winning RFPs, and they want to do the right things too. As I'm looking at the poll questions, it reminds me, poll we did earlier this year, one of the questions was the biggest barrier people were seeing to collaboration within their organizations. And I think the number was just under 40%, something like 37% of people noted that no funding for new initiatives.
Yeah, I think that's a good point. And let's go ahead, Eric, and see what we're looking at with this population today. So funding is about 17%, which is interesting. So it's enrollment and engagement. So that actually is a common piece that we see, is that you build it and they will come, and that's not always necessarily the case. So we can dive into a little bit around some of that. I think it's having a multimodal, multidisciplinary approach to how do you identify, and we'll talk a little bit more in some of the coming slides about early engagement and often engagement. And every day in a pregnancy, every day in a NICU admission is a critical opportunity to engage with that member and make a huge difference on the future for both that family, that mother, as well as that baby. So interesting. And then I see very closely is provider collaboration. So we do hear quite a bit about that and can address some of that specifically in a NICU setting. There's what you call managed and unmanaged opportunities. So we can show you some data points that we see and we can help you to see within your own population how you can have a bigger impact around collaborating with your providers. So appreciate your feedback on that. What we've done is there's lots of different levers that we could pull for today's webinar, but to try to condense this down into some quick applicable ones that you can bring back to your organization, tying into what we just saw as the second most popular topic is provider variance. So we'll show you some data points from our data analysis that we've done and monitored over the years to show how the same provider treating the same type of condition can have so much variation. How is that possible? And what are some specific steps that you can do so that you are not vulnerable to that pattern, and looking at appropriate levels of care and length of stay. As we look to the upper right corner, length of stay, utilization management as a lever is a key. Having that specialized utilization management, we'll talk more about, specific to NICU and maternal and infant health. Case management engagement, building that trust, building that early, building that often, that can be a key component there. Looking at post-discharge. So Brian touched on a couple of the different areas. We'll go into a little bit deeper in the coming slides around some of those levers that you can impact around post-discharge. The level of care just starts once the family and the babies go home. It doesn't stop. So we'll give you some practical tips there, as well as payment integrity. So we'll talk a little bit more about that. Many of you on this call likely have a payment integrity relationship today. We'll give you some thoughtful questions on, are there ways that you can fine tune that specific to maternal and infant health so that you have that safety net on the back end with some of your claims. So I'll go ahead and turn this back over to Brian and have him kick off with our first lever around provider variance.
Thanks, Wendy. Just to illustrate, you need to, if you're going to be serious about this, dig deeply into your data. So what we've done here is we pulled health plans, top 15 providers. Obviously, it's blinded. And you can see here, there's a very large variation in care that isn't always explained by length of stay, DRG weight, or volume. So bringing value to your providers through oversight is a key here, as opposed to them getting the sense that you're looking over their shoulder and determining care that they think they have a handle on. So as an example, let's dig into this chart. When we analyze a NICU, we're looking for threads of continuity between markers like length of stay, cost per discharge, and DRG weight, which clearly is the acuity level. This demonstrates a wide range of care philosophies among this particular provider network. So if you just look at the first two providers, 594 and 886, they have similar acuity levels, right? But 594 has a 40% higher length of stay and bills 19% higher cost per discharge. Look at facility 112 with roughly half of the average DRG weight of provider 886 and half of the length of stay. Yet their average cost per discharge is 26% higher than provider 886. If you take a little, if you look a little bit lower down to the midpoint of the graph, at the blue highlight, you'll see facilities 218, 784, and 84 compiled in a row. Very similar DRG weights. Average cost per discharge varies from $51,000 to nearly $14,000 to under $5,000. And when we dug deeply into this, what was responsible for the average cost of discharge, we naturally assumed, as you might, that, well, that facility with a $51,000 average discharge must have had some really expensive babies to push it up. In fact, it was not the case because we had already pulled some of those outliers out of this scenario. So just as an illustration, we wanted to show you that when you dig deeply into this, oftentimes you're going to find that there are disparate, what we would call general philosophies of care against a provider network. And one of the things we do to combat that is our goal across the board is to provide continuity in best practices of care across the board through an entire provider network. And so we know that if you are going to work to control your costs in the NICU, you've got to collaborate with your providers, and you have to bring value in that because without behavior change, you're just not going to see your costs reduced, period. Let's jump to that next slide, Wendy, if you would. Thank you. So the other piece to this is length of stay and the drivers behind that. There are two sides of this coin, UM and CM, which most of you are probably aware of. And the key here, I think there are three main components. One is timely and consistent UM. Number two is case management engagement. And number three is the actual leveling of that care on a daily basis. So if we look at timely UM management, immediately upon the NICU admission, the UM team's focused on standards of care, treatment plan, each baby, and communicates with the hospital to ensure that the baby is progressing to discharge daily. A validation of the diagnosis, ensuring that the accuracy of primary and secondary diagnosis to ensure that the baby meets the clinical criteria for NICU billing and follows throughout the inpatient. In our UM program, we would never deny a baby being in the NICU or NICU care. That's not the question here at hand with you. And the question is, do the clinicals match the billing for NICU care? It's an important piece to this. Keep in mind that, a case can quickly kick into outlier status with an inaccurate secondary diagnosis. So primary and secondaries are really important. Number two is case management. You heard me mention earlier that we use a team approach. So our CM team, as well as the extended care network, gets called into play as soon as we get notification of a NICU baby. It's within 48 hours. And case management, that early intervention assures that the family is ready for discharge, whether it's in 2 days or 222 days. We know that the engagement of CM is important because the delays in discharge often happen when, simple things like DME isn't ordered on time, special formula isn't ready, the family doesn't have the support they need at home, et cetera. There's social drivers that are stopping them from going home safely. We look at CM as the lifeline to management post-discharge. And so we know that keeping the same case manager as much as often as we possibly can in place helps create, as I mentioned earlier, those relationships and in sharing in those lives of the family, it helps us to identify and solve for any of the social determinants and health challenges that are happening all the time. And then number three would be the leveling of care. UM and CM work together from day of admission, key to impact, and of course your physician fees go hand in hand with that length of stay. And so the daily leveling of care means that we are looking at, especially in that first 5 to 7 day block, leveling on every single day. And oftentimes we find that due to resource constraints, health plans are forced into a situation where they are approving 5, 7, 10 day blocks of care initially. And what we find is when we go back and look at what actually happened in the NICU, that the leveling of care doesn't match what actually happened, nor does it match the claim. So those are all things that come together that we know are important to managing all of that. I know it sounds like a lot, but if you just take the continuum in steps, one step at a time, what you're going to find is you can manage those steps, and they do come together to create a picture that is more effective and more efficient. Just very quickly, we added this slide to make sure that you don't fool yourselves. So oftentimes we will get a call from a health plan that says, we pulled some of our data, we looked at it, and we looked at our NICU length of stay, for instance, and it doesn't look like it's too far out of whack from the rest of the country. It may be a little high, on the high side. Do you guys have ideas, about that? And as we start to look at the data, when we look at the lengths of stay, oftentimes we start to notice trends in that data that are interesting. In this particular case, you can see that there's a very high 2-3 day length of stay across this health plan's entire provider network. So you can see we're comparing those against our national benchmarks. And we know intuitively, before we even dig into the claims, when we see something like this, that we know in most cases that many of those 2 and some of those 3 day lengths of stay shouldn't actually be billed as NICUs, because when we dig into those, we find that the clinicals don't support the billing for NICU, even though those babies are lumped into an average length of stay. And so when we back up and now we take a new snapshot for some of those babies that wouldn't necessarily qualify as NICU babies, the length of stay, the average length of stay actually goes up, and people then recognize, oh, so we do have opportunity with our length of stay. Those short lengths of stay that are erroneous were actually skewing our perception of where we were. Let's go ahead and jump to the next slide,
Great.
Wendy.
I can go ahead and take these last 2 levers, Brian. So one of the pieces that Brian was talking about in case management is post-discharge variables. So we see when we're speaking with health plans, their model of case management may not begin till that mom and baby are home. One of the models that we've seen most effective is to solve as much as you can proactively before that family arrives home. So as Brian was sharing examples with DME or other post-discharge planning, to make sure that that can intervene as early as possible. One of the pieces on the screen there, it says that having, the post-discharge variables can drive costs even more than inpatient. So looking at that and seeing potential complications that can occur in that postpartum period is really what is the objective of case management. So proactively solving all of the social determinants. I don't need to say to anyone on this call the importance of solving, identifying, and resolving, I should say, social determinants. So, and that's something that it's going to change as their needs change. So having that a very solid plan for how you are going to approach that as an organization. One of the pieces that Brian was mentioning about was emergency room admissions and readmissions. So the last place anyone wants to see a newborn baby is in the ER. There is almost 100% chance that that baby is going to be admitted to the hospital. ERs are not equipped in most cases to handle that baby. So having that trust built with the case manager in a long-term situation can help be that first line of defense, where maybe the incline is to run to the ER, but maybe there's other opportunities that can be discussed with that case manager. So having a case management team that is available, that's built that trust prior to coming home, we see that not only helping with your engagement, helping with your trust, and helping with that long-term case management. A couple of times during this session, we've mentioned the importance of that postpartum period. And all of you on this call are representing different geographic areas, but hopefully now we're getting very close to having 12 months postpartum covered for Medicaid patients, which is such a critical milestone that we've had. Having that case manager available for 12 months through the most, which can be the most critical fourth trimester of postpartum, where mortalities and other complications can arise. So having that virtual safety net there is really a key. So some of these levers here, I know we're not sharing anything unique, but just taking a look at how are you working across your plan How are you working and collaborating together? Are there resources in other departments, other programs that could be bundled in? Because what you want is if you have programs and resources that are being offered, you want them to be utilized. So really, really a key here. And your long-term case management is going to be your best safety net to catch those rising risks, which I know that Brian has mentioned. A lot of times we see that people come in with defined risks, and there's not a mechanism to be monitoring as risks develop, as people change their needs. How do you then adapt and make sure that you're adapting to those needs? The last lever in our 4 levers here is around payment integrity. So Brian touched on this just a little bit. And one of the things that we see as a recipe for success is that oftentimes payment integrity programs are pretty general. They are set more at a dollar threshold. But what we see when it comes to NICU claims specifically, taking a look at all the claims. NICU claims are extremely complex, and it takes someone understanding the clinical as well as the claim side of that. So looking at that and seeing, does the utilization management strategy that you put in place match to what the claims are that are coming back? So looking at every claim, you're going to find, just like in Brian's example with the volume versus the cost, you're going to find that by volume, it may be worth looking at every single claim, because if you can find some low dollars in there, you're not just looking for those high $1 million claims, but you could find some savings in quite a few claims if you're looking at every single claim that's touched. NICU is a very complex, I don't need to explain that to everyone on this call. There's lots of different factors that go into determining the diagnosis as well as the DRG. So that's where looking at every clinical validation is going to help you ensure that what you authorize is what you're actually paying the claim for. And again, in addition to setting some of those thresholds, not just at the dollar value, but looking at it from every NICU incident being reviewed, having an expertise in NICU. So do you have some case managers? Do you have your RN reviewers that have an expertise in NICU that can really look at that and can balance out that clinical as well as that claim side of the house? So I think these are just some of our successes that we've helped guided our clients and built our foundation around payment integrity. As you look at your payment integrity, there's an opportunity, I'm sure, to fine tune some of those dials to look at some of these call to actions that we've highlighted. So this actually brings us pretty close to the end of our webinar here, and just wanted to highlight some of the actionable steps. And before I review some of these, I think the biggest thing is, do you have a strategy to understand your data? You can't manage what you can't measure. So looking at that strategy from a comprehensive standpoint, first of all, thinking back to our poll question, ensure that maternal and infant health is a corporate priority. This isn't something that just lands in a pop health area or in a utilization management team, in a case management team. It takes your entire organization. It takes the resources that in your health equity area. What are you doing there? How do you make sure that all of these resources are coming together to circle around these families to make sure that every need that's identified has an opportunity for resolution? This is the biggest piece here, and often a question that we get is, well, can I just understand, how do you understand what is going on in my population? The only way to understand that is to look at your data. So when Brian was looking at the provider slide, or looking at the average length of stay, he was highlighting some of the hidden areas in there that we're looking at. Looking at your data and understanding your data for where are some of those discrepancies, where are some of those drivers, especially with your length of stay. When your length of stay is low, it doesn't always mean that that's good. It means that maybe there's something to look just one layer under to see, okay, are there any unnecessary or avoidable NICU expenses in there? Managing and integrating your maternal and infant care program. Brian kicked off with that, talking about it's not just about a NICU strategy, or it's not just about a maternity strategy, but it's about having that coverage across the continuum to make sure that you have all areas of risk covered. And postpartum is one of the most important times. I think there was a study that was just done from the World Health Organization talking about, as well as ACOG came out with some new guidelines as well, about how important it is to engage with the members early and often in that postpartum period. So get in there and engage with that member prior to having anything happen during that postpartum period. And this is one, the last one here, results make the most compelling RFP story. We all know that since COVID, especially in the Medicaid environment, RFPs have really picked up. Those that were in an appeal or those that have possibly delayed releasing the RFP, it seems like all of that is coming back at once. And rather than talking about what you plan to do, go into action now. If there's one or two steps that we've said today that can help you understand your population and you can put into action, and that helps you in your RFP, tell what you're doing versus what you plan to do. We can't underscore enough how much that has helped our clients, and just really puts you in a very much advantage in replying to that RFP. So this brings us to the end, and what we would love to do is we want to hear from you. So hopefully we've sparked some interest or made you pause and think about some things that you could do today in your organization to think differently about how can you have an impact on rising maternal and infant health costs. And we'd love to just have you write in the chat if there's anything that comes to mind around that. Also, we do have both of our contact information here. So we'd love to get, if you want to send us an email as well, or do both too. We just love to hear from you all. I think one of the things that we find in the maternal health and infant health space is that it really is going to take a community to change this trajectory. So the more we can collaborate together and we can learn from each other, that's what it's going to take us all working together in order to start to see some impact and some outcomes. So with that, let's go ahead and see if there's a couple of questions in the chat here. Brian, I see one here for you. Go ahead and read this one to you. What are the biggest barriers you see for a health plan getting started in their maternal and infant health initiatives?
I think what we find typically is we're in a world today. We live in the reality of money matters. It really does, and there necessarily must be a dollar return on investment in advance of someone agreeing to put resources, time, money, humans toward changing any of these results. And so in most cases, when health plans reach out to us, they are asking us to help them qualify and quantify the changes that can be made through that entire continuum by putting dollar ROI to it as well as an outcome ROI. And so the challenge is there. And what we know is when you're looking at that entire continuum, oftentimes if you're looking at it in segments, maternity is sometimes very difficult for health plans to put a hard dollar ROI to, because a well-functioning, proactive maternity program is built to stop things from happening. And oftentimes, finance folks have trouble counting dollars for something that didn't actually occur, right? And what we do know is when you tie the whole continuum together and you look at the total cost of your newborn population, you can have enough hard dollars in optimizing your NICU and post-discharge unwarranted readmissions, ED visits, lots of key success markers can be quantified in dollars that can help make the case initially to invest in the entire continuum of care, which includes maternity. And oftentimes, when it's done well, there's still a dollar return, a healthy dollar return in the dollar side of the ROI. Also, you've heard me say a couple times, there's an ROI in dollars and there's an ROI in outcomes and quality. And those two things have to be synced together to create a plan that gets any senior executive team on the same page with an initiative like this. That's my take.
Great. Appreciate that. I see another question that came in. It says, what are effective ways to build trust with mothers on Medicaid? We struggle to enroll and see patients in programs during pregnancy. I can take a stab at this, and Brian, I'm sure you also have some thoughts, but this is actually a very common question that we get. And I think maybe it was last year, we did an entire webinar on building and keeping trust. And one of the biggest things that we see is engaging early. So especially if you have someone who has had a NICU baby, or it could also be in maternity, engage early and engage often. And one of the things is really have active listening. So I always think it's easy to understand trust through a story. So one of the examples that comes to mind is we were talking with a mother who seemed a little agitated. The case management nurse had talked with her a couple of times, and she said, no, I'm fine. And she said, well, there's a couple of things bothering me. So number one, we found out that she was having some postpartum depression issues or signs. So what that nurse did was they stopped everything. The most important thing was solving in the moment. So our case manager went into action. She called 13 different providers till she found one that could see her that day. And later that member called back and said, I'm pretty sure you saved my life that day. Thank you for not just sending me to a phone number for me to do that. I wasn't in a state where I could do that myself. Another example that we see too is we had a mom who was, she was very engaged, and then one day she just didn't seem like she was that engaged. Something as simple as she said, well, this is going to be our last time we speak because I don't have the money to pay for my cell phone bill anymore. Something as simple as having a cell phone, which we all take for granted. And our case manager quickly went into action and said, I see that you actually have a program to have your cell phone paid for. And that's where it takes a village to know all of those resources that are available. So having that active listening skill to not just pass by that, but for that member to say, okay, this has nothing to do with what we're talking about, but if I'm cut off from my mechanism that I can connect with you, that case manager got that member enrolled in that program to have assistance for that phone to be paid. So I think the message here is solving for what is needed in the moment, put aside what everything else is that needs to be accomplished on that call, and solve for what is being presented, and listening without judgment. I think that really goes a long way. So the next time they're intervening, maybe you can, get to some of your assessments or other things that you needed, but solving in that moment and treating that human need right in the moment. So I don't know, Brian, if you have any other ideas around building trust that you've seen.
No, I think that's, I live off of those stories, Wendy. We all do here at Progeny, as well as so many of you on the call today. I think too, just making a note that, our digital experience really provides a high level of member engagement. People don't often think, you mentioned the Medicaid population. There's a perception out there that the Medicaid population won't use a digital app. All of our data says to the contrary, that they enjoy it, that they use it. And again, a big piece of that digital app is the monitoring of what's happening real time. So that if a mom is asking questions that point toward the need for intervention, that we can take care of that real time. And as you were telling the story, I I could hear Madeline Zabo, our SVP of Clinical Services, talking about closing the gap. The gap needs to be closed real time between anything that the member is experiencing that's stopping them from getting the care they wanted. And the difference, I think, and Wendy, your point is that the story about the woman that really needed help and the case manager stepping in on her behalf, she kept her on the phone while she was securing that appointment as she reached out to the, whatever it was, 13 different providers. Closing the gap real time is what matters. And if you have the ability to keep that same case manager in place, those relationships matter, because that trust bond is what affords the sharing from the member, to the case manager. Otherwise, if it's a call center and it's one case manager this week and another one on Friday and somebody different on next Thursday and then next Tuesday, you don't really understand what that family's going through or what their needs are, and the relationship just isn't there. So I think your answer is right on the money.
I see another question in the chat too, and it's very similar to this one, but this one is earlier in the period. It's about enrolling. So having strong enrollment, what are some tips around that? So some of the ideas that we have worked with health plans on is looking at how many different sources can you utilize to identify members who potentially could be pregnant. So you've got your state ID file, you've got your ER claims. Now, one of the things with claims is there's a long lag time between that. So what you want is, if you have a multi-dimensional enrollment identification file, you're going to hit some of those triggers that aren't going to be lagging like a claims file would. But looking at state enrollment files, looking at ER claims, look to other population health programs that you have. There may be some identification of pregnancy in those. So for instance, if you have a diabetes program, maybe there's something that would identify if a member is, pregnant in there. Also, what we've seen is having proactive outreach. So we do a lot with our health plans to create a proactive marketing campaign around enrolling. Oftentimes, to enroll in maternity programs or other programs that can be buried in the website. But are there other ways that you can proactively push out notifications? Now, obviously, texting and other things come with rules around how you can reach Medicaid populations. But I'd say just think about being multimodal. Think about having multiple sources, so you're not putting all your eggs in one basket to identify that pregnant member.
Very good. Wendy, I see a question here relating to, the question is around NICU and providers and the typical amount of time that we see that it takes to start to change provider behavior. And so I think that's an important one, and it was high on the list too. So if it's okay, I'll take a stab at this first, and you can, of course,
Sure.
add anything you think is relevant. The time is not as much as you think it would be. For us, over the first 90 days of any engagement with a health plan partnership, we are experiencing real change in provider behavior. Now, I will say we do have a little bit of an advantage, but I'll qualify this in a moment, because we use a program that we call Baby Tracks. It's our proprietary EHR, where we have housed for the last 20 years all the clinicals on every NICU baby we've ever managed. So we have millions and millions and millions of data points in that database that our managers use to inform the conversations that we have with providers. However, point is, we help to change that provider behavior by bringing data to the table. And you have the ability as a health plan leader to pull your data. So if you are going to work on a collaboration initiative with your providers, pull your data, make sure it's clean, make sure it's accurate, make sure you're sensitive about how you share it, put it into a format that compels improved results, and start to work with your providers on what you're finding and what you want your goals to be. That's how our program works. We know that it works, and we know it works well, and it's been our recipe for a couple of decades. One of the key markers you're going to want to pay attention to is your denial rate. So across the board, our key marker is less than 3% denial across the board. And for us, that's the proof in the pudding with how well our program is working with providers on the front end. Because anytime we see that spike, we know that there's something not working the way we intended with the communication with the providers. Wendy, is there anything that maybe I missed or anything that comes
No, I
to
think that's a very comprehensive answer. And, no one out there will argue if a provider is not liking what's happening, they are going to be very vocal. So you're right, to have that marker be that denial rate really illustrates the collaborative nature that can be built with the providers. I see we're running right up on time. There's one question in the chat that I did want to address, and it was around food as medicine. And this definitely is a trend, I'll call it, where you're seeing a lot of different opportunities to provide food and provide it specific to conditions. So specific during pregnancy, what are the nutritional needs? You see it in chronic management programs, disease management programs. So what is our point of view around that? Here's what I would say to that is, when you look at a program like that, make sure that it's encompassing the entire family unit. Because we know that if someone is food insecure, for instance, and they're struggling with that, so maybe their food need is from a medical standpoint, a condition standpoint, or it's out of need. Just make sure that it's including the entire family unit. Because we know that when programs are not focusing on the family unit, that individual is going to make tough choices, and they're likely going to be the one that goes without that food program. So making sure that any program that you're offering is taking into needs of the entire family unit. We partner with several of our health plans who have relationships with different food companies, and we are happy to have our case managers be another referral to that. We don't directly have any association with different food as medicine or food distribution organizations, but we are happy to be a resource for that. So I think that they serve a purpose, but also look at how do you then teach, how do you have a resource there for that long-term need and for that entire family. So I see a couple other questions, but I know we're right up at time, so I'll go ahead and thank everyone for their time and turn this back over to Eric for any last parting words he would like to say.
Yeah, thank you so much. I would just like to thank Wendy and Brian for the great presentation today. Obviously, they shared a ton of great information. Maternal and infant health is a big issue in Medicaid. As Wendy kind of mentioned at the top, there will be a maternal and infant health track at our annual conference this year, which ProgenyHealth will be presenting on. So we invite you, please come out to Indianapolis next month, September 11th through the 13th. You can find more information about our annual conference on MHPA's website, mhpa.org. ProgenyHealth will be presenting. ProgenyHealth will also have an exhibit booth, so please stop by. I'm sure Brian and Wendy would love to talk to you not only about this presentation, but the next one they'll be doing at the conference as well. So with that, I want to thank everyone for the time this afternoon and have a great rest of your day.
Thanks, everyone. Great to be together.